All right, Jonathan, thanks for joining me today. For a little background for those watching or listening, we have a mutual friend, Adam Sudd, who's down there in Texas, or was down there in Texas, um, who thought that we could have a good discussion about a topic that we're somewhat on opposing sides for.
Mhm.
The topic today that we decided on was, does red meat increase risk of cardiovascular disease and/or all-cause mortality? And do alternative production methods, so things like pasture raising, organic, et cetera, whatever sort of method you prefer, result in products that do not carry any risk. So that's kind of what we'll be trying to get into today. But before we get to that, do you want to maybe introduce yourself, tell everyone a little bit about yourself?
Sure. My name is Jonathan Mendoza. I am a family nurse practitioner and a doctor of chiropractic. And I have a practice in Austin with my best friend. We have a health and wellness clinic where we do hormone therapy, balancing really, lab testing. We do vitamin IVs. We do various other types of things. So from the natural holistic standpoint, that's very much our world. And we do a lot of lab testing to basically customize nutrition for anyone who comes in here.
All right, and just for myself, I'm a naturopathic doctor here in Vancouver, BC. I am a proponent of plant-based nutrition in particular. I've been plant-based myself for over 10 years. I'm a public speaker. I'll be speaking at this year's Planted Expo here in Vancouver, as well as going down to Oregon for a conference down there, one out to Toronto for another one out there. And I recently helped Simon Hill, better known as Plant Proof, with his book, The Proof is in the Plants, which was just released a couple months ago. I got all sorts of other projects on the way, but I also love spending time on social media, educating others, and hopefully the goal with this is to help educate the masses as well. Now, I don't know if you have a preference or like I've got some stuff up ready to go. You're welcome to jump in first too. I'm really cool either way. Obviously, we'll
Sure.
just present our own kind of arguments for this first.
Sure. So I'll go ahead and just lead with the background of it. So
Yep,
I'm
go ahead.
making I'm making a claim that ethically raised animal meat or animal products does not cause an increase of heart disease risk, or does it cause risk of heart disease to increase brain disease? You can look at it the same thing. And whenever I talk about ethically raised meat, you're right. It is pasture raised, is grass fed, free range, if you will. And in the labs that we have looked at over the past 7 years, we've measured every single diet possible. We've looked at paleo, keto, gluten-free, of course, vegan, and more recently, carnivore diet. And that's the one for people who don't know. Carnivore diet is where you essentially eat very clean organic meat with organ meat attached to that diet as well. And just looking at all the labs, we've been able to really look at trends, I guess, if you will, amongst the diets. First and foremost, every single diet is deficient in some kind of nutrient, with the exception of the carnivore diet, because they eat the organ meat, which is usually including the liver. And so there's a lot of nutrients in the liver. So they still supplement regardless, right? So they're taking liver meat. But whenever we looked at the meat consumption in Austin, we have the ability to look at a lot of different people's diets, because there's so many healthy, conscious people here who want to look at how their body functions. And so when we order these labs, we order very progressive labs to look at biomarkers that look at inflammation. And whenever you look at heart disease, you're going to look at inflammation that's occurring in real time. And so the markers that we look at in the labs will tell us if current inflammation is going on, or if something on the horizon is serious is going to happen. And it's very interesting, because with the meat consumption, especially if it's very clean grass-fed beef, you're not seeing an increase of these inflammation markers for heart disease. And it's the same type of markers that you'll see in vegans, where there's not an increase in inflammation either. Obviously, we know a very clean plant-based vegan diet should not cause inflammation. But what's really interesting about it is you go back to the idea about whether red meat causes inflammation. And I don't think it's necessarily the question of, does red meat cause inflammation? Is it the way it's processed and metabolized in the body? Does that cause inflammation? And so looking at the diets, I sent you a case study. And the case study was taking 8 different meat eaters and 8 different vegans. And like I said, we've done these labs for 7 or 8 years, and the labs that we're looking at pinpoint inflammation that's occurring very seriously when it comes to things like atherosclerosis. And so if you're trying to pick up cardiovascular disease, then you're talking about something that's dear to everyone. And something as serious as heart disease is one of the things that I think needs to be looked at in a different light when it comes to our approach towards it. And so with these markers, we can now say our nutrition that we were taught even when we were, maybe 20 years ago about how, chicken, egg yolk and bacon and meat is bad for you, that cholesterol is going to clog your arteries and cause heart disease. It's just completely false. Well, if you look at it, we really have an issue about the way food is processed and metabolized in the body, and most people can't handle it. And I think that's the issue when it comes to heart disease, is that most people cannot handle whatever.
Sorry, did you stop there? It cut off right before your last word or two there.
Okay. No, yeah. The going back to the study about it, when you came to red meat, I know that you were on the opposition because I'm guessing as a plant-based individual, there is a resentment towards the idea that red meat is good for you, because I know that there's so many other things that are attached to that statement. But if you just look at the data, we're looking at it, it's really clear. If you look at very clean processed meat, it's minimally touched. When you're talking about, the cow is not stressed, and the way that we metabolize and broken down in our body is tolerable. And it's really fascinating because it goes against a lot of our thinkings when it comes about red meat consumption.
Okay, so first I just want to touch on that last point about me being resentful towards red meat consumption simply because of the ethical implications or environmental implications, whatever it is that you want to talk about. I do have a problem with the term ethical meat. I'll say that, which is why I'm glad you actually clarified what you meant by that, because I don't see that as an appropriate term. But I would not consider myself someone who's biased when it comes to the science on red meat. For example, I will go on record as somebody who's been vegan for 10.5 years to say that low-fat dairy consumption and fish consumption are absolutely, or can be absolutely, parts of a healthy diet. I'm not one to, make false claims around the harmfulness of those foods. Now, when it comes to red meat, I think it is incredibly clear. And I'll actually just share my screen as I go through a few things here. Now, share screen. Okay. Now, starting with this by Zong from last year, this was looking at processed meat, unprocessed red meat, poultry, and fish intake with incident cardiovascular disease and all-cause mortality. And this was large. It was pooled from 6 prospective cohorts, 30,000 people, with a great contrast in red meat consumption. So what's really important to look at with a lot of these studies is the contrast in meat consumption, and seeing that, in Asian countries, you might get the difference of, a serving a month versus a serving a week, and you're not going to see much of a risk there because there's not a decent contrast exposure. Now, when you look at this particular study, you look at unprocessed red meat intake, we're going from 1.3 servings a week to 6 servings a week. So, 1 serving a week up to almost 1 a day. And that's going to be a good enough contrast exposure to see risk. And they did a dose response here, where they actually found that just 2 additional servings of unprocessed red meat in particular associated with risk and was statistically significant. That's impressive because that's such a tiny increase. Now, I know that one could argue that, and just for the record, for anybody watching, we did share resources ahead of time, so hopefully I'm not catching anyone off guard here. But now one could argue that, look, this wasn't pasture-raised, there are other compounds, there's higher fat content, all of these things. Well, in my view, one of the most important factors with regard to cardiovascular disease is actually saturated fat intake. And so we can go to another study here that's really great. This was again last year, and they performed a substitution analysis. So they looked at what happens if you substitute, I believe it was 3% of calories from animal protein with plant protein. And they looked at specific sources of the animal protein as well. And once again, if maybe I'll just pull up the images here because they've got some good images of this. wherever it is. Yeah, so when you're looking at red meat, substituting 3% of calories from red meat protein with plant protein led to a 13% decrease in risk of all-cause mortality and in men, and a 15% lower risk in women. If we go to cardiovascular disease, again, 12% in men and 18% in women. And what's so incredible about this was it was adjusted for the fatty acid content. It was adjusted for saturated fat content, for monounsaturated fat content, for polyunsaturated fat, for fiber, basically any dietary variable that would actually skew towards benefiting from plant consumption. So they stacked the cards against plants, and the plants still come out on top when substituting directly for red meat, which is why I do think it's really important to consider what are you replacing a food with. And this does largely remove the argument about the fatty acid composition of, say, a pasture-raised organic meat product.
Right. So
yeah.
well, I would like to make a comment on that, and I know where you're going with this.
Yep.
So first of all, I would look at those studies and say, what are the labs they're measuring? Because it looks like you're heading towards LDL and BMI, which, first of all, I think
I wasn't going towards BMI because they adjusted for that.
Okay, but I also see here, whatever labs you're going towards, I see they're going towards LDL as well. And so most of these things are based off of LDL, and you start getting into like PUFAs, and you start getting into poly and monounsaturated. The thing is, we know that oil is going to be inflammatory at a certain boiling point, regardless of whether it's avocado oil, whether it's coconut oil, and whether you're looking at it, you can even make the case to say oils are not the real big issue, because what you're looking at is the process of those oils, the process of those fats. Now, if you minimize the process with it, you got to imagine that you showed me a study right now that shows me processed versus unprocessed foods. And we're already off to a start where we're saying, all right, we're still going to compare process. Look at the idea of saying whatever.
I was looking at unprocessed.
Okay. So whenever you're looking at it,
the last one was,
right. So I saw this study that you were looking at before. The problem is that you're comparing LDL. And the issue.
No, I wasn't. There was no LDL in that. That was red meat consumption and actual outcomes, health outcomes.
Okay, go ahead. Go ahead with the next slide.
So let me just finish my kind of series here, and we can get into the whole oils and oxidation, inflammation, all of that as well. So now getting back to saturated fat, as that is like I've already shown, independent effect, independent of saturated fat, red meat increases risk. But if we take that into account, we do see that with saturated fat consumption, based on the MnSync paper in the World Health Organization, you can very accurately predict the LDL cholesterol rise that you get from something like, from saturated fat consumption when you look at the other factors like the PUFAs, MUFAs, and all of that are going into carbohydrates, what you're replacing with. On that note, I don't know how familiar you are with this, but the European Atherosclerosis Society paper, this one I definitely sent to you. I actually sent it under a few different categories because it was an important one. LDL or low density lipoproteins cause atherosclerotic cardiovascular disease based on converging lines of evidence. So we have genetic data, epidemiologic data, we have clinical studies, we have preclinical studies, and their criteria for causality is listed right here. And evidence one, or grade one evidence for each of these criteria. So plausibility, LDL and other ApoB containing lipoproteins are directly implicated in initiation progression of ASCVD. And if you experimentally induce higher LDL or other ApoB containing lipoproteins, you do get atherosclerosis in all of the mammalian species studied. That would be largely the animal data. Now, the strength, it's incredibly reliable as far as the lifelong exposure to LDL particles and the risk that is accrued by that. For biological gradient, again, same sort of deal here. We have the dose-dependent effect of LDL cholesterol. It's a log linear association. Temporal sequence. Again, we have lipid disorders, Mendelian randomization experiments demonstrating longer term exposure leads to greater risk, even at the same level of LDL, as achieved in cohort studies or randomized trials. Specificity, again, that goes back to Mendelian randomization, only altering LDL values and seeing risk. Consistency of association, just to point out the consistency, I've got this image right here. You can see no matter what method you're lowering LDL by, it's incredibly predictable, the risk decrease. So PCSK9 inhibitors reduce LDL by the largest degree and lead to the largest reduction in risk as well. And I was at coherence. That's just, again, going back to a lot of what we've already mentioned. And then reduction in risk with intervention. I just showed you that image. Lowering LDL by basically any means lowers risk, particularly if it lowers ApoB. So with all of that, how does one make the argument that LDL cholesterol, or specifically ApoB, if I want to be super specific, is not causally associated with cardiovascular disease?
The reason why is people who are on statins have low LDL, but yet they still have heart attacks. So if you're treating LDL, so hold on a second. If you're treating LDL, you're treating an outdated measurement. And here's the problem. Just what I said. If you're treating LDL with a statin, most likely you're trying to lower it. Well, all your hormones are made from LDL. So one thing I definitely don't want to do to basically my metabolism is lower my ability to make hormones. And if I target my LDL, there's a cascade of events that happen. And here's the big problem with that study. And you sent me another study, so I know you know about it. You talk about oxidized LDL. All right. Mm-hmm. Now, oxidized LDL wasn't even mentioned in that study. And the problem is it's still only a piece of the argument. Now, here's the thing. If you're looking at inflammation markers, and I hope you show my studies as well.
I will.
Okay. Here's the deal. You're showing me a bunch of markers and tests that are based off LDL and BMI still. Even oxidized is still a little progressive, but it's not the full picture. What we're dealing with is inflammation. And here's the problem. If something becomes oxidized, it can come from many different variants, especially genetics. Just look at the ApoE gene. When you're looking at LDL, keep in mind, it's a progression that's going to lead to hormones. So you're basically talking in line of the same mentality that's basically gotten us into trouble the past 30 years, and that fat is bad for you. Fat is not bad for you. Fat is a necessity. I know, but here's the thing. Here's the thing. Animal fat is not bad for you. The process of metabolizing and breaking down can be an issue. And if you're focusing on the LDL, you're still missing the boat, even oxidized LDL. Because here's the thing. The test that I showed you is measuring something called myelopyrrole oxidase, which is MPO. Now, MPO is a white blood cell inflammatory marker. So if I'm measuring LDL, here's the thing. How do I know how much inflammation is building in my arteries in real time? Because the definition of atherosclerosis is plaque buildup, especially when it comes to microvascular disease. So if I'm looking at LDL, it doesn't tell me any microvascular damage that's going on in real time. And all these studies that you're about to show us are based off an outdated marker.
So for starters, you said that statins don't reduce risk of having a heart attack. Here is a meta-regression of statin treatment lowering risk of cardiovascular mortality in randomized controlled trials.
So why do people still have heart attacks on statins? Why do people still have heart attacks on statins?
Because it's not 100% protective. You're lowering risk later in life. I'll show you exactly what I'm talking about.
Hold on. So Matt, you're showing me a bunch of really nice scientific mumbo jumbo. However, the thing is, the methods that you're basing your whole argument on is been 90 years of us getting in trouble for basically the same thing. There's nothing. Treating LDL is the reason why heart disease is still the #1 killer 90 years in a row in America. It's not the issue. It's inflammation from the production of metabolized cholesterol.
So do you think people have ideal LDL cholesterol levels in the general population and they're dying of heart attacks?
Yes, of course they are. Because why would people be?
Where's your evidence for that? Where's your evidence that the general population has ideal LDL cholesterol levels?
The general population does not. Here's the thing.
So that's my point.
Look. If you have a person that's on a statin that has an ideal LDL and they still have a heart attack, explain that. Why do they still have a heart attack?
I will. I'm going to right now.
Okay. So yes, I would love
if that. So if you look at this blue line, let's say you have an LDL cholesterol of 125 milligrams per deciliter, right? This is your trajectory for risk. Now, the cumulative LDL cholesterol exposure, you hit that threshold if you have 125 around just under 40 years of age, and you have a very low risk. And as you age and you have further exposure to that LDL cholesterol level, your risk continues to increase. Now, if you have a lifelong lower LDL cholesterol level, so less exposure of your arteries to LDL cholesterol, or again, more specifically ApoB, you're going to have a slower trajectory towards that risk, leading to a lower risk by the time you're, say, 100 years old, if you live that long. Now, if you're treated with a statin, what happens? You don't get treated with a statin from birth. You've been on this high trajectory all the way until, let's say, you're 50 years old, and they're like, oh, you know what? Your LDL cholesterol is higher than we want. Now you lower the slope of that trajectory, but you are still at increased risk. You've already passed that threshold of risk. You're just lowering your risk relative to people with similar LDLs who don't end up being treated with statins, which is what I showed you in that previous trial. Those are randomized controlled trials of statins versus placebo showing. Can I finish my point, please? So what I showed you previously in that previous slide was that lowering or having a lower trajectory of LDL through your entire life leads to lower risk. But when you have randomized controlled trials of placebos versus statin treatment, showing that statins lower your risk of dying from cardiovascular disease, that is a benefit. If you're expecting 100% protection, that is like saying seatbelts don't protect you against death in car accidents because people still die. That's exactly what you're saying.
Matt, do you prescribe statins to your patients?
I do if they need them.
You really do. Okay, so here's the deal. There's other methods to balance out cholesterol besides just statins. And if statins were really, hold on. If statins were, besides the #1 selling medication for the past 30 years, if they were that effective, you still would not have people having myocardial infarcts after they've been on statins for 5 or 10 years, and heart disease would still not be the #1 killer in America. You cannot sit there and tell me that treating LDL is the issue. If you go look at the others, no, here's the thing. If you go, I totally disagree. The inflammatory markers that you have not even mentioned, here's the question, here's the follow-up. You would not justify cardiovascular disease based just off LDL. You, and I know you would order a few more tests to confirm if there's inflammation building, because once again, LDL, so you're solely basing heart disease off of LDL, no other markers.
No, I'm not. No, I'm not. You're strawmanning me. You're strawmanning me. It's ApoB is the primary risk factor, but inflammatory markers like CRP, like MPO, like adiponectin have not been shown to actually increase risk of events in and of themselves, and I have them in daily randomization data. Here, let me just read off what MPO has been known for, and you can bring it up too. I can let you share. I can let you share your screen.
Yeah, that's okay. So
we can just go
I'm going to read.
I'll read verbatim. Yeah, can you just share your screen and show everyone else who's watching as well?
Perfect. I would love to. So host disabled. Well, if you could let me share the screen, that'd be nice.
Sorry, hey, my mistake. I will try to get to that right now. Video allow.
I'll just read this in the meantime. Multiple levels of evidence suggest an association between MPO and cardiovascular disease, including coronary artery disease, congestive heart failure, arterial hypertension, pulmonary artery hypertension, peripheral arterial disease, myocardial ischemia, reperfusion-related injury, stroke, cardiac arrhythmia, and venous thrombosis. Elevated MPO levels are associated with a poor prognosis, including increased risk for overall and CVD-related mortality. And if you think about this, the link between MPO and CVD can at least partly be explained by MPO-dependent oxidation of LDL and HDL, subsequently leading to a cholesterol accumulation in the arterial wall. The issue is when you have oxidized LDL, you cause arterial damage lining, like to the lining. And what happens with that is that you're going to have accumulation of white blood cells. And once again, if you say MPO and adiponectin are not definitive markers for inflammation, these are coming straight from the American Heart Association and the American Diabetes Association. So I don't know what other association you think would probably know more about heart disease than the American Heart Association.
So I mean, do you agree that the American Heart Association also suggests that LDL cholesterol is a causal risk factor? They put out a position statement with the EAS. No, they talk about LDL cholesterol. I can pull it up if you like.
It's such an outdated measurement.
No, but you just cited them, and you cited the fact that they are the American Heart Association as evidence. So would you accept that LDL cholesterol is also?
I would say oxidized LDL, and that's what I would accept.
Okay.
And so I would not accept just regular LDL as any type of marker other than you have cholesterol. That's it. If you have oxidized cholesterol, which is caused by MPO, now I'm looking at real-time inflammation occurring. Think about it. What is plaque buildup? It's oxidized LDL. It's not regular LDL.
Yeah, and where does that oxidation happen?
Where does it come from? It comes from corn oil and vegetable oils and processed
Where does it happen?
vegan oils.
My question was, where does it happen?
It usually happens in the liver.
No, it doesn't. It happens in the lining of in the subendothelial space of the artery wall, right? Do you know how ApoB interacts with the artery wall? Do you know about the pathophysiology there?
Yes, of course I do. And here's the thing: you're focusing. Hold on, you're focusing on particles. And if you really want to get into it, let's say ApoA. Let's try to increase everyone's size of ApoA and make everyone's HDL really big, so it can scoop up the ApoB and the LDL and put it back in the liver. But here's the issue: even HDL become oxidized too, because guess what? If oxidized comes in the form of HDL oxidized and LDL oxidized, you have plaque forming in real time, which means if MPO markers are elevated, you have oxidized LDL and HDL. So your whole argument of LDL being the sole factor, you can have oxidized LDL.
I didn't say the sole factor.
I know.
I did not say the sole factor. But you're strawmanning me again.
You're focusing on one thing.
Because it is a known causal risk factor.
90 years, heart disease is still the killer because of mentalities like what you just said. You need to get with the times.
Okay, so provide me with look. You've quoted something.
I just did.
I've allowed look at my
labs. Look at my lab. Bring up my labs. Bring up my labs. Let's talk about those. Because we have research. We actually have research labs.
I'm trying to let you share your screen. I have given you rights to share screen now. You should be able to share screen and pull up your own stuff and share it with everyone. And I've given us the ability to both share simultaneously if we'd like as well. I figured it out. Are you there currently? I don't see you.
Yeah, I'm trying to get in here.
Yeah, okay, so there you go. So, okay, you're sharing that. Yeah, pull up whatever you'd like.
So, here's the thing in real time.
Yep.
I got a couple of things that you can see here. So, the evolution of cardiovascular disease looks like MPO right here. And hopefully you can see this. But you're looking at here, you see this little thing down here? This is called MPO. And what happens is it attaches to things like LDL and HDL and it makes them dysfunctional. And what happens is it builds lesions in here that form thrombosis. And what you're looking at is basically plaque building up in real time. And if you're looking at some of the markers for looking at how bad of a risk we have, we can pinpoint this marker. Here you go. You mentioned hsCRP. Well, that's probably in the middle right here if you're looking at thrombosis and you're looking at atherosclerosis building. If you look at MPO, MPO is a definitive marker for plaque instability. So if I'm looking at saying, okay, let's measure the LDL. Okay, maybe it's in range, maybe it's not in range. What's inflammation doing to the arteries? If a plaque is about to rupture and form a clot, I want to know that within a few months or maybe a year if something's going to happen. MPO tells me whether or not a plaque is so unstable that it's going to block off and form a stroke within 6 months. If I'm measuring LDL, I'm not going to pick up a potential heart attack or a stroke happening in 6 months if I'm solely focusing on LDL. And so if you look at this marker, what we're looking at here is you're in serious condition if you start building inflammation, and LDL on the spectrum of it, I think I probably have a picture, which is pretty good to measure. Let's see here. There we go. So risk of disease. You're looking at it right now. You have oxidation and LDL that's building at the beginning stages of it, right? So there's damage. Now you have hsCRP that starts building and you have general inflammation. And now you have basic endothelial dysfunction. That's the arterial lining of the wall that's basically becoming under attack. The next two markers are really important. Now I left out Lp(PLA2) because Lp(PLA2) is a marker that measures plaque building inside the walls. But I want to look on basically the lumen, and that's where MPO comes into play. So if you're looking at it here, you're looking at it real time. Here's the Lp(PLA) marker, and here is actual plaque building up in the artery. There is no mention of regular LDL because oxidized LDL has already infiltrated this. Regular LDL is long gone. We're dealing with oxidized LDL that's basically deteriorating the arteries. And the problem is, if you're focusing solely on just the heart, this is not occurring in just the heart. This is occurring in the brain as well. And if you look at it, you can literally see all that Lp(PLA), which is white blood cells, and MPO basically circulating in the artery, ready to go attack and make this plaque more unstable. And right here, MPO is a specific marker of plaque vulnerability. So when it comes to overall, looking at cardiovascular disease, here it is. Here's this beautiful picture I was looking at. Here it is, lifestyle concerns. Yes, we can possibly, through some diet, change their diet and make LDL a little bit lower and maybe have a little bit of intervention with statins. But here's the issue. If hsCRP starts rising, we still have a problem in our hands. But if you look at MPO and Lp(PLA2) and you see those sky high, you have a serious cardiovascular event happening in several months. And the truth is that if you look at ApoE, there's a direct correlation with MPO. So, I'm thinking like, okay, MPO is probably the higher end of what you're looking at. Yeah, you can measure ApoB and measure ApoA and start nitpicking all the cholesterol. The issue is, who cares? You already make inflammatory cholesterol. So if you make inflammatory cholesterol, are you making inflammatory plaque? And if you're making inflammatory plaque, then you have a serious problem on your hands. And so what we're looking at here is these are the markers that we measured in the study that I sent you over, which are actual labs that our own clinic runs. So when you look at these markers, we picked out 2 markers specific for what we're talking about right now. I still say MPO is the definitive marker for cardiovascular disease, and hopefully in 20 years, people will finally recognize. But if you look at the top 8 people, they're all meat eaters who eat a very clean diet. And we ruled out, if they're, pre-diabetic, smoker, they have to be physically active and so forth. If you look at their MPO for the meat eaters, they're well below the cutoff range of 470. If you look at the vegans, clean vegans, by the way, we had to find clean vegans because not everyone eats healthy who's a vegan. You looked at the MPO, and even this one over here is a little bit higher, but they were all kind of roughly the same. Not too much, not too bad. You could make a little case for some of these being better, but they're still the same. The crazy thing is we know that a vegan diet is not going to cause an increased risk of heart disease. I can firmly say after looking at markers specific to arterial inflammation and plaque accumulation, that clean, ethically raised meat is not going to cause an increased risk of heart disease. The only thing that I found that was interesting, which was really interesting on this test, is that there's a decrease in adiponectin production in vegans. And the crazy thing about this thing is that adiponectin, according to other standards and recent labs, has also been an indication of arterial inflammation, as well as been found to be very low in diabetics and Alzheimer's. And so I cannot explain it, but I found it interesting that if you look at this adiponectin, which is a marker for diabetes, insulin, and mitochondrial health, it's high and in range within meat eaters. And it's very, very low in vegans across the board. Now, I don't want to say that they're at risk for heart disease because it's not what I'm saying. However, I can firmly say, looking at these labs, the meat consumption that these people are eating is not causing heart disease. However, the lack of meat in the vegan diet is lowering their adiponectin, which is a hormone that's supposed to be protective against heart disease and mitochondrial health. So that's the only thing that I looked at as far as data. And so if you can show me what you were showing before, I mean, this is essentially what, kind of counteracts everything that you talked about, focusing just solely on, cholesterol particles.
No, so my question here would be, do you care more about mechanistic data, or do you care more about health outcome data?
I care about what my patients are doing face to face. So if they feel better and their heart disease, so that's what I care about. I don't, research is great, and you could talk about randomized control studies and all that, but you and I both know we're clinical. All right.
Yeah, okay, can I just rephrase my question for a sec?
Yeah.
So would you care more? Let's just theoretical here. Would you care more about these numbers on the page being, according to you, better or worse, or would you care more whether that person has a heart attack or not? If you only have one or the other.
I still don't understand the question.
So let's say you have data. What's a good example? Let's say that LDL cholesterol LDL cholesterol markers we could look at, vegans had better LDL, meat eaters had worse LDL, but then at the end of the day, higher LDL didn't lead to cardiovascular disease. What would be more important to you, the lab values that you saw there, or whether or not it was actually resulted in cardiac events?
Are you asking me if I want to see someone have a cardiac event and see if my statements are justified? Is that what you're asking me?
No, I'm asking you, just given the data that we have, like I'm not asking you, let's see if this happens. I'm saying based on data, we have lots of observational data. We have observational data on these markers you mentioned as well. Would you rather see data showing that these values actually correlate with cardiac events, or would you rather have these mechanisms you've gone over showing that, this is involved with this pathway, therefore it might lower risk of atherosclerosis or something? Like, what would be better data to you if we had actual data on the cardiac events, or the data, or basically speculation on these mechanisms that we know about?
I still don't understand the question. What I'm saying, hold on a second. Let me try to answer it. But what I think I'm hearing is, I'm going to try to answer it the best way possible. I just want I want people to get better, and time will tell, obviously, for certain conditions. However, what you're basically arguing is focusing on something that has been the norm in healthcare for the past 30, 40 years. And I don't agree with it being the standard of treatment.
Well,
and,
you haven't,
hold on. But I don't understand what data you're talking about. What I'm showing you here is numbers that if you're not ordering, that's okay. But in the future, hopefully you are. But if you're looking at these numbers, you're looking at inflammation. Really, why are you a clinician? You're looking at trying to help someone get healthier. And the way that they get healthier is they reduce the inflammation in their body. Okay, so here's the thing. Hold on. You're looking at data focusing on metabolism. Now let's focus on metabolism. Here's the thing. If genetically speaking, we should be looking at SNPs, right? Let's look at ApoE. If you solely went off genetics and you say maybe 50, 80% of your cholesterol is based off genetics, if you have an ApoE factor of E4, you're 50% risk for Alzheimer's and cholesterol issues on top of that. Now, am I going to just succumb to that because genetics gave me those cards? No. I can lower inflammation in real time and win the battle against heart disease in patients if we give them the right start. And if you're looking at the right markers, it doesn't matter about the diet. That's what I'm saying. The diet's it's a moot point. Because I'm looking at. Go ahead.
Yeah. So you're basically saying that ultimately these values are more important than how you got there, right? Is that what you're saying? Like forget about on the left.
I don't understand how what are you asking? I don't understand.
No, so I'm just asking, forget about, on the side, you have JB meat, KB meat, whatever, all the way down vegans. Forget about that for a second. If you just had, without knowing how they got to those values, if you just had the values for MPO and adiponectin there, and maybe you had their ages or something, that would be enough for you to tell what somebody's risk is, generally speaking.
Yes, of course. That's the whole point of this discussion.
Okay. So do you have data showing that those values actually lead to worse, not just that they have been shown or they're speculated to be in certain mechanisms or have been shown in animal models to contribute to certain things, but actual data on humans showing that higher levels of one or lower levels of the other lead to higher rates of actually having a cardiac event?
So let me get this straight. You want to look more at more data, and I think I probably sent you a lot of data towards the end.
Yeah.
Wait, hold on a second. Adiponectin inhibits MPO in ischemic brain tissue. MPO is a better marker than CPR for acute coronary issues. MPO is a great biomarker for coronary artery disease. Circulating adiponectin inhibits monocyte adhesion to endothelial cells and inhibits macrophage transformation to form. Now, I could say all that stuff just like you do. Now, here's the thing.
Let's go through them. Let's go through them.
Oh my God, are you serious with this? Okay.
Let's go into them.
All right, let's go. Let's go ahead and go.
I've already done it.
Let's go. Perfect. That's perfect.
So this is the first one. This is reference number what, 5?
I don't know which. I guess rolled adiponectin and central nervous. If you want to focus on adiponectin or MPO. You could. It doesn't matter to me.
Yeah. Let me just make sure.
Let's just start with adiponectin.
Let me just make sure I'm looking at the correct one here because I've got it open on my end too. So is reference number 5, I believe, is what you clicked on there. Is that
no, it's going to be, I think I put 6. Let me see. Was it 6? Yeah, maybe 6. Okay. Try that one.
So that was reference 6. Sorry, let me just pull that one up then. Adiponectin protecting cerebral ischemia. Is that the one that you have open?
No, I have central nervous system.
So that's not number 6.
Actually, it's number 2. Let me see. I'll open this one. How about that? You can go to number 2. And that's the rollout adiponectin central nervous disorders. Okay.
Yeah, let me just pull that one up then as well. Okay. So yeah.
All right. So I'm going to go to the So adiponectin is a hormone produced by adipocytes. It's the introduction on the second paragraph. Adiponectin signaling has been widely studied in multi-system diseases, for example, obesity, diabetes, dyslipidemia, atherosclerosis, and comorbid metabolic dysfunction in the setting of cardiovascular disease such as hypertension. Serum adiponectin levels appear to be inversely correlated with the presence severely of metabolic dysfunction. And that is lower serum adiponectin is seen in patients with disease.
Yep. Okay. And have you gone into the studies that this review cites?
Oh my God. I mean, I probably have studied them in the middle of the night and gone through all 30 or 40 of them. Yes.
So my point is, so you know that they're all mice studies, right? They're all done in mice. Pretty
A
much
lot of
all
them
of them.
are,
I think just about 100%
a lot of
them are
animal
in mice.
studies. Okay, so what's your
Yeah.
point?
Yeah, so do you know about the translation rates of animal research to human research?
If you're going to discredit everything I'm saying right now, that's fine. The problem is
I'm
no,
not,
that's fine.
I'm
I'm going to say, here's the thing. When you're progressive and you look at different things that are different from the norm, people are going to nitpick at you. And if you're nitpicking the translation of, no, here's the thing. Look, you want to look at animal studies. Why do we have hormone replacement from pig DNA? Why is thyroid coming from pig DNA?
Because it was studied in humans. That's why, because we studied it in humans to show that it actually has an impact.
And we also study in animals before we do humans, which is what we used to do before 2020. So,
and the vast majority of the time, those studies fail in humans. There's a very low concordance rate between animal trials and human trials. And the reason I bring that up, and if you wouldn't mind me sharing my screen here, the reason I bring that up is because I have multiple, where is it? That was, we'll go to that later. So we have, man, I can't find it, right here. So I have multiple Mendelian randomization experiments on adiponectin in humans and whether or not it actually associates with having cardiovascular disease or coronary heart disease in this case. For one, there was, and we can go through the specifics if you like, but overall our findings do not support a causal role of adiponectin levels in coronary heart disease pathogenesis. We have another bidirectional Mendelian randomization. Adiponectin is unlikely a cause of coronary artery disease, although we cannot completely rule out the possibility. Hey, they're saying there might be a possibility. If there is, it's probably very small, but basically they did not find an association here. There is another one here looking at adiponectin observationally. Plasma adiponectin and BMI are inversely associated. In contrast, genetically high plasma adiponectin is unlikely to influence BMI.
So I have a bunch of studies. Look, I have a bunch of studies here that still don't even talk about.
Okay, but my point is, can I just please finish? Can I please finish here? So the point is that all of the human data looking at basically randomized to having higher adiponectin or lower adiponectin for your entire lifetime does not impact your risk of actually having a coronary event, or if there is any possibility of that. And this is looking at diabetes here as well. It's incredibly small. So the point is that we can look at these mechanisms in mice and that, but this is bottom of the barrel, bottom of the evidence hierarchy. When we look at the actual human data, this just does not pan out, and adiponectin does not seem to actually contribute to risk. Hold up. Let me finish that thought, please. So adiponectin does track. Yeah, adiponectin does track with certain lifestyle behaviors that may positively or negatively influence risk. Sure, I would concede to that. But in and of itself as a marker, it is not good and does not actually tell us anything about risk. That is my point.
Well, that's interesting, because according to all the studies that I sent you and I've seen, and the own studies that we've personally done that I showed you, you asked for data. I'm giving you data right there. Yep. Now, here's the thing.
But that's not good data.
Hold on. No, here's the problem. Well, the thing is, when you create data, you're going to be studying our data in a few years anyway, so it doesn't matter. If you're looking at adiponectin, if you're upset about the fact that it's low in vegans, that's the conundrum. I'm not. You're assuming bias. But here's the thing. Here's the thing. If you're looking at diabetes, let's focus on diabetes for a second. Yep. Diabetes and heart disease is the same.
I got it right here.
It's the same thing. It's the same microvascular issue because it's the same plumbing. So if adiponectin is a hormone that goes and protects your artery lining, and a diabetic produces a low amount, who also probably has metabolic syndrome, which produces a low amount, guess what? You don't have any hormone protection in the artery lining. MPO comes from white blood cells. Like I said, once again, treating inflammation and not just cholesterol particles. You're looking at plaque instability. Now, all those articles that I sent you even beforehand that talked about MPO, those are from actual human studies as well as Boston Heart. So if you're looking at that, it's the same as Cleveland Clinic. They're talking about the same progressive labs, and they're ordering the same ones, talking about these same things. I have videos of cardiologists talking about how they do a disservice to their patients if cardiologists are not ordering MPO. So I'm sorry. Well, I'm sorry if this is a new conversation and you want to focus on outdated material. I'm sorry.
This is not how this is recent research in humans, and you provided animal research. Now, if you want to go to MPO,
I actually provided human research, but you just keep discrediting that, which is fine.
No, because you provided some for MPO. You did use some observational research. I'm not discrediting that. You keep strawmanning me like that. I'm not. I'm understanding what you're saying. But again, so MPO concentrations but not genetic variants at the MPO locus are independently associated with risk for total and cardiovascular mortality. So what that tells us is that there might actually be confounding to those MPO values. There might be other things, again, raising your MPO levels that, that also lower risk through other mechanisms. Now, I'm not saying that there's no chance, like you were talking about diabetes. There is actually a really good review out there looking at how diabetes accelerates atherosclerosis. And one of the potential mechanisms, although we don't have enough information yet, is actually possibly adiponectin. So I wouldn't even rule that out there. But the largest one seems to be the insulin's impact on atherosclerosis. That being said, for the general population, which is what we're talking about for the most part here, none of this pans out in human data. And in the best available human data, the highest point of the evidence hierarchy, other than like meta-analyses, the Mendelian randomization is right up there. Whereas a lot of what you're pulling from is down at the bottom of the evidence hierarchy. So unless we're creating our own hierarchies for evidence here, we have to side with the best available human data that we have.
I don't agree with that, because in the history of science, well, the history of science is questioning everything. All right. And here's the thing. You started by questioning this argument. And the thing is, you haven't swayed me one bit, but hopefully the viewers have listened and said, hey, guess what? This guy's talking about clean meat. It doesn't cause this inflammation. I'm probably going to go to my doctor and order this test, because I'm not waiting around on my traditional doctor who orders normal labs to see if I'm going to may or may not have a heart attack off the statins that he keeps prescribing me. The issue is this. If doctors are waiting around for them to tell them, here's the new data, that's fine. But the progressive thinkers of our history has always questioned and said, let's find out more and research more. And what I'm telling you right now is new. That's fine. You can admit it. It's fine. But the issue is, in a few years, diabetes will be looked at as heart disease and the same thing. And you're looking at basically treating mitochondrial disorders, basically insulin regulation, and you're trying to get good sleep. That's essentially what we look at with health long term. So
then just question, do you have any, like, out of the research I presented, the Mendelian randomizations, I sent you a lot of this data ahead of time. Do you have any issue with the MRs that I presented? And just as a side note, because you mentioned oxidized LDL earlier, and I had this open, I forgot. Actually tracking ox LDL when you adjust for other lipid markers, like your ApoB, for example, ox LDL actually doesn't independently predict risk. I just want to throw that out there.
Well, to answer your question, here's the issue I have. Another way you can have oxidized LDL is to have glycated sugar into your body. Now, here's the problem.
That's bad. I agree.
Hold on a second. So here's the thing. If you have two forms of looking at ways to create oxidized LDL, let's just say it's three forms. It's protein, fats, and carbs. Any which one of those can cause oxidized LDL, because they all can be converted back and forth. The issue is, once again, are you ingesting something that's causing something to be oxidized, or are you genetically converting something that's causing it? So either way, what's causing the oxidation? It's MPO again. Once again, it comes back to MPO causing the oxidized LDL or the HDL that forms the plaque.
So then why doesn't, so you're saying that, you're actually saying that, because earlier you said it's a better marker than LDL, you're saying that ox LDL doesn't predict risk. Now I'm confused by that.
No. What I said earlier was oxidized LDL is a decent marker. However, it's better than regular LDL, but it's still not as good, which I showed, as MPO. It's still an inferior marker.
It tracks very well with LDL though. Like ox LDL and LDL track incredibly well with each other.
Well, like I said, here's the thing. According to Boston Heart Diagnostics, which basically just studies.
Again, that's an appeal to authority. I don't care what somebody says. Like, to be frank, what I want to know is where's the data. I want to know where's
there's data right there. I don't understand. As long as it doesn't agree with your data, you don't care about it. But look, there's
pointed out
data right there. There's data right there. And I cited all this picture right here. I cited all this from a cardiovascular study.
It's a picture. What are you talking about?
All the sites that are down there. Please don't give me that.
Yeah, no.
Look,
and I went through
all these markers right here. Look, you want to cite? Yes. So you're going to dismiss it because these are actual.
I'm not just dismissing it on the
right here.
Okay, can I finish, please?
That's from the New England Journal of Medicine. That was published in the New England Journal of Medicine. Everything we're talking back in 1999. So I'm sorry.
So outdated? Is it outdated?
No, it's actually, it was progressive. It was progressive because we're still focused on LDL after 30 years. Apparently no one was paying attention then. We have to say it again.
Okay.
Atherosclerosis is a chronic inflammatory disease. LDL becomes inflammatory.
I mean, it is, but it's not caused.
Okay.
No, it is. I want to rephrase. I want to rephrase, please. Let me rephrase. It is inflammatory, but it's not caused solely by inflammation. It is caused, that whole inflammatory cascade is triggered by ApoB originally.
Actually, no. Oxidized ApoB can actually come from like glycated ingestion of fatty acids and triglycerides, all that. So no, that's not true.
Where's
Actually,
your evidence for all that? Where's your evidence for that? That is more predictive than say ApoB. Do you? Okay, just yes or no. Do you or do you not have evidence for that?
I mean, I'm gonna have to look it up because now you're wanting me to cite stuff I didn't send you. So I'm basically have to look it up in all the stuff I have right now. And if you're still not agreeing with what I'm saying, look, dude, I'm not gonna send you more stuff if you disagree with it. The thing is this: if you cannot, if you cannot see right there and share the screen with it, if you cannot see this physician talking about atherosclerosis and inflammatory disease,
physician, if a single doctor says something, it's fact. Is that what you're saying now?
And it happened to get published in the New England Journal of Medicine.
Okay,
yeah, maybe.
Do you want me to cite like, I don't know, the past president of the American?
No, you're not making sense. You haven't discredited my thing at all. You just basically said I'm wrong. You just said I'm wrong.
No.
If you wanted me, look, no.
Can I finish
because if you wanted me to come on and just tell me, if you wanted me to come on and say I'm wrong, that's fine. Here, the thing is, if you want to have an open debate about the fact that meat is not causing heart, well, I presented evidence and it's still not good enough for you. So I don't know what else to do at this point.
So no. So I just want to clarify. You have presented mechanistic data largely and some observational data, which the Mendelian randomization data, the randomized controlled trial data around LDL cholesterol, the large-scale epi on red meat consumption, which actually, honestly, this debate's really skewed away from red meat in a sense.
Because I already proved it.
All of that is higher. All of that is higher on the evidence hierarchy than what you've presented, pretty much across the board. This actually is another Mendelian randomization looking at CRP levels and coronary heart disease. No association. C-reactive protein concentration itself unlikely to be a modest causal risk factor in coronary heart disease. We also have data on statins. I know you dislike those, but statins reducing risk of having cardiac events regardless of CRP level. We have the data is incredibly consistent here, and thus far you haven't actually pointed out any holes in any of the data I provided thus far, and you haven't really provided counter arguments to the data I provided that is better, aside from just saying you're forward thinking.
Let me put the biggest hole in your argument. 680,000 people die a year of heart disease. Yep. Nothing has changed with the model that you're talking about. And it's not going to continue to get better until you actually think outside the box and start treating other things other than what's been established.
So you're saying that because heart disease risk or heart disease rates are still so high, that the messaging around heart disease or the treatment plan, so to speak, all of that needs to change, is what you're saying?
Yes, of course it does. Okay. What are we even talking about?
So do you think that the public is following the recommendations currently?
No, because they're listening to you.
No. Do you think the public, the general public, is following the current recommendations around, say, diet?
No, because 1 in 3 people are pre-diabetic.
So how are the guidelines to blame? How are the guidelines to blame if people aren't following them?
Because they're following what the doctor tells them. If they say, "Hey,
no, they aren't. No, they aren't.
Oh, really? It's the patient's fault, not the doctor at all. The doctor has no say in the patient's health.
No.
Are you serious? Are you serious?
No.
No.
You're strawmanning me again. You keep strawmanning me.
No, you're twisting it around on me and you don't like it. So you're telling me right now. No, if you're going to say it's the patient's fault for them having heart disease, that's BS. Your whole diet premises is teaching them how to get healthy. It's not prescribing pills. It's teaching someone how to grow food and how to cook food at home. It's not giving them a pill like a statin.
Hey, again, I'm not somebody who prescribes statins first, unless it's familial hypercholesterolemia or something. I am someone who works on diet first. You're assuming my position on these things without actually talking about it, but that is not the case. What I'm saying is that we actually, I'm happy to go through the data. I'm a data guy. I've got all the research here.
I obviously
showing you how poor the actual adherence to dietary guidelines is. And so if you're going to blame the dietary guidelines, you're blaming something that isn't even followed. How does it contribute to the current issues that we have with regard to heart disease if people aren't even doing it?
Hey, I hate to break it to you, Matt, but something radical like banning sugar during COVID would have been something so radical that it would have dropped heart disease in half. But if you're still adhering,
where's your data for that?
Oh my God, are you serious? Just think about it. The problem we have is sugar.
Where's your data for that?
You're focusing on animal fat. You know it both well. It's sugar. The sugar is the problem.
No.
So basically,
no. You're changing topics again. You keep changing.
I'm not
topics.
changing. I've already said. Red meat does not cause heart disease. I've already said it, and I'll say it again.
Yeah,
red meat does not cause heart disease. It does not cause heart disease.
Our debate was supposed to be about red meat. It is
And
not
I already
about
proved
sugar.
it. It doesn't.
No,
it doesn't.
you haven't proved anything. You literally haven't proved a thing. You've shown
No,
me a case. You've shown me a case series of your own patients that you didn't do any adjustments for. There's no actual
You asked for
statistical
data.
analysis there.
You asked
Yeah,
for data.
yeah,
I don't
and
understand. You're a data guy. I showed you data. You still didn't believe it. I don't know what else to do. I don't know what else to do.
So if I had shown you
Show me some of
data
your data. Show me some of your labs. What labs do you order?
I don't care.
You don't care about your labs?
Cases. No, I don't care about individual case reports or case studies. What I
What?
care about
Why
is the
not?
actual research.
You don't care about the individual? You
No, I
care
do
more
care
about the mass than the individual sitting in front of you.
No.
Wow.
You're straw manning. You're straw manning left and right,
God
and it's
bless.
brutal.
All right, dude, this is ridiculous. This is okay. Look. Look, I understand you're a great practitioner. That's wonderful. The thing is, I'm telling you right now, nothing you said is going to sway my mind. In 5 or 10 years.
So that's the sign of bias. Is that not?
No. Well, listen,
I'm not going to change my mind. That to me sounds like bias.
Matt, I presented evidence to you countless times over.
You did not present evidence that trumps the evidence I presented, nor did you point out holes in the evidence.
No, the thing is, it wasn't going to sway you either. Don't come in here like you were looking to talk openly.
I've actually made posts about stuff I've been wrong about because I was proven wrong about those things.
But I'm not wrong about that.
No. Oh my God. I'm just saying, you're saying that I'm not willing to change my mind. I've literally publicly admitted to stuff that I've gotten wrong before. And actually it blew up into be one of my most popular posts, which is funny enough.
Matt, I don't care about social media, Matt. I don't care.
What I'm saying, I'm just pointing out that
you're great. I get it. That's fine. You're graceful. That's fine. I don't care. I have better things to do on a Tuesday night than debate you about minuscule data. If you don't want
so you don't have data, you don't have good data.
I just showed you data, Matt. Matt, this is ridiculous. Let's bring up my screen again, and you can see numbers and then consider the data and consider it a bunch of data considered over 7 years. It's 7 years of 1,000 tests compiled. It's data.
And
what else?
You don't have data on actual cardiac events in humans that trumps the Mendelian randomization.
Oh my God! Oh my God! You don't either. So I don't understand. You don't have anything to show me. You don't have any. You haven't presented anything. No, your LDL argument is obsolete, and it's based off of BMI measurement. You haven't provided
a single argument for it.
It's obsolete. It's obsolete. You're still talking about statins. You're talking about statins. You're talking about statins
and presented some pictures. That's what
you prescribe statins. You prescribe statins.
Yeah, because they save lives.
Okay. Well, keep telling everyone to eat soy while they're at it too.
I will, absolutely. And if you want to have another debate on that, good luck.
No, there's no point of having a debate. Just know that soy can lead to inflammatory estrogen, and if you can't clear it out of your liver, there you go.
Oh my God, that's just unbelievable. I've never heard such a. Do you have data for that? By the way, I'd love to see it too. Just
oh my God, dude, just go look it up yourself, man. I'm tired of this. Jeez.
All right.
I appreciate it, Matt. You have a good one, buddy.
You too. Oh man. Just for the record here, I'll just so just to close out, because that was a hot mess. Sorry if it got a little heated. That's not. I know last time I did this sort of thing, it was a lot more chill. But he clearly wasn't acknowledging my questions. He wasn't actually presenting arguments against the data I presented. He didn't present any counter arguments to me talking about how poor animal research is as far as it translates to humans. He had not a single argument about LDL other than sharing some pictures with mechanisms and whatnot, which is like, he had a source for one of them, I think. And yeah, the evidence is very clear, even though we got really off topic of red meat. Red meat consumption, it seems above 2.5 servings a week increases risk of cardiovascular disease. Largely driven by increased saturated fat consumption, leading to higher LDL cholesterol. And yes, LDL cholesterol causes heart disease. So there you go. Goodbye.